invite the first speaker, Dr. Vamsi KONUGANTI. He is center head of the I Foundation Metupalayam, and he is a senior consultant cataract and external diseases at Metupalayam, Tamil Nadu. He's going to talk about medical management of pterygium, what is new. Over to you, Dr. Vamsi.
At the outset, good afternoon, everyone. Good afternoon, everyone. I'd like to thank the AIOS Scientific Committee to give approval for this instruction course, and would like to thank the chairman of the AI Foundation, Dr. D. Ramurthy, and Dr. Shirish Kumar sir, to include me in this instruction course. And friends, as we all know, pterygium is a fibrovascular degeneration lesion of the conjunctiva that occurs only in humans. Clinically, it presents as a triangular-shaped conjunctival hyperplasia with its apex directed towards the cornea. The most common location of pterygium is interpapillary fissure and papillary conjunctiva on the nasal side. And it impairs vision. And according to Sharik et al., wherein a meta-analysis was done, what happened was the actual incidence of pterygium is around 12% in 2018, and meta-analysis following that, they've denoted that around 1 to 30% of the population gets affected by this pterygium. So I'll be speaking regarding the medical management of pterygium and what's new. The topics are, I'll be talking regarding the medical adjuvant therapies, a comparison of these options, and is there any role in primary and secondary pterygium, and medical therapy replacing surgical options. Yes, we have some new drugs which are coming out, which they claim that it replaces surgery. So coming to this citation and the techniques, the primary surgical technique for pterygium management and the recurrences, what happens is these are the different types of techniques which are used for pterygium. And we at AI Foundation have done a 15-year study by Koduvar et al., which is published in 2024. Compared to the normal studies which have been quoted, the incidence of recurrence of pterygium is around 0.3% compared to the 1.3 to 14.4% of the conjunctival autograft, which seems to be the best technique for avoiding recurrence of pterygium. And compared to the other techniques also, we did the 15-year study ruled out that we have better outcomes, but anyhow, recurrence is a problem. And the mechanism of pterygium is quite complicated, and they say that angiogenesis and vascular proliferation are the key factor in the pathogenesis of pterygium. And as we all know, vascular endogenous growth factor, VGFR2, and different mechanisms are denoted to note that the pterygium causes pterygium actually. So targeting these methods, and the new drugs are coming to target these methods so that we don't get that proliferation of pterygium. And the medical now the medical management is only an adjuvant therapy as for it now. So these adjuvant therapies are we have anti-neoplastic agents like mitomycin C and 5-fluorouracil, anti-VEGF, that is bevacizumab and ranibizumab, and cyclosporine eye drops. Mitomycin C, as we all know, it's an anti-neoplastic agent, and it's an alkylating agent that inhibits the DNA replication, leading to cellular death. And it can be used both post-operative pterygium surgery with varying degrees of success. And primary pterygium, the recurrence rate is around 4, and recurrent pterygium is around 4 to 39%. In our hands, it comes to around 3%. And the dosage is around 0.01% to 0.202 and 0.04%. Regarding the different options of mitomycin, all the studies have ruled that it can't replace the congenital autograft what we do. So the congenital autograft is the primary treatment for a primary pterygium actually. So so what's the role of mitomycin? Mitomycin plays very good role in case of high-risk pterygiums, young patients with high chances of recurrence. So in those patients, when we combine the congenital autograft with mitomycin, it has better results. The safest option is around 0.02% for 3 minutes. The dreaded complication of this is scleral thinning and necrosis, but for this dosage, not much of studies have revealed that the side effects occur. And coming to 5-fluorouracil, it's a pyrimidine analog in which DNA synthesis blocking proliferation of inflammatory cells such as fibroblasts and decreasing the healing response. It can be used as eye drops, but they have the complication of epithelial keratopathy, which occurs in 10%, and there is a 10% recurrence. And the interlesion injections are much better, and it halts progression, but the biggest complication is granuloma formation and vascularization, and can be given the dosage of 0.1 ml in a 5FU and 5 mg in 1 ml syringe, given intralesional. This is usually given post-op for preventing the recurrence of this one. So this is the chart which depicts the use of efficacy of 5-fluorouracil. But whatever it is, again we come back to the same this one. Congenital autograft has the primary good response compared to all the adjuvant therapies. Coming to the next, this one, anti-VEGF agents, that's bevacizumab and ranibizumab. These are recombinant monoclonal antibodies capable of binding to VEGF to neutralize its actions and reduce fibrovascular proliferation, vascularization. They can be used as injections or drops, and ranibizumab can be given as injection. This subcut interval before and after surgery. The safety profile is it's well tolerated. And if we compare the different techniques, again we come back to the same this one, wherein congenital autograft has a better this one compared to the adjuvant therapy. But it can be used in case of recurrent this one. But the only thing is the cost factor. Especially in India, the cost factor is the most important this one. And most of the pterygium affected patients are, the economic, this one, they belong to the economic category wherein the cost matters. So primary pterygium doesn't have much benefits, but recurrent pterygium for reduced vascularity for 3 monthly doses can be given. And cyclosporin 8 drops, these are immunosuppressant agent that acts on T cells, thereby inhibiting interleukins, which reduces the intensity of inflammatory response. It has mixed results. The efficacy and safety profile has a mixed result. And meta-analysis it says that significantly reduces regression, and it can be used in dosage of 0.05% and 0.1%. So when we compare both all the medical adjuvants, as we see, the congenital autograft has the lowest recurrence rate compared to other treatment options. And the mechanism of mitomycin C and amniotic membrane and anti-VEGF agents and fibrocell, if we see, the lowest recurrence rate is in congenital autograft. In our hands in iFoundation, led by Kadur et al., the percentage is quite significantly reduced compared to the international studies. Coming to the emerging pharmacotherapeutics, that is curcumin, RHO kinase inhibitors, nintedanib, and role of lipid metabolism in pterygium. They say that the statins, what we take for high lipoproteins, they also have a role in reducing the pterygium. So whoever is consuming statins without knowing the benefits, we have been protected with from the pterygium. So, Rho kinase inhibitors is the one wherein it inhibits fibrosis and cell this one, and it's a novel post-surgical treatment. Nintedanib has this one wherein it has a promising target therapy for pterygium cells. So this is the new kid on the block. They say that it's a multi-target tyrosine kinase inhibitor ophthalmic solution which is available in drops, and its aim is that it's a new surgical, non-surgical alternative. It has undergone 2 trials, and now it is in the phase 3 study done by Cloudbreak Pharma based in Irving. And it says that it acts on 3 mechanisms of pterygium. The causative factors of all the 3 cycles it takes care and effectively reduces pterygium size and symptoms in patients with primary recurrent cases, as denoted by Whitcup et al. In 2024 paper. So efficacy is in reducing vascularity, lesion size reduction, and safety profile. It has a potential as a disease-modifying therapy, and it has a regulated process. So I think, friends, as we all know, right now the medical treatment is only an adjuvant, this one, to prevent the recurrence. But we have newer therapies which are emerging, which they claim that it reduces the incidence of need for surgeries. Thank you.
Thank you, Dr. Vamsi. One question to you, most of the medicines what you have mentioned are either given before surgery or during surgery or after the surgery. Do they replace surgery?
No, that's what, as the talk rightly predicted, nothing to replace the congenital autographic as we speak right now.
And you mentioned about that CBT, which is under trial, that tyrosine kinase inhibitor.
Yes.
So, what is the kind of role it has? Is it like it is just chemo reduction? Is it going to reduce the vascularity and size of the pterygium? And
Exactly, as you pointed out, it reduces vascularity, and then what they say is the pterygium has a homeostatic effect on this one, wherein the fibroblasts and myofibroblasts, they proliferate and they cause the pterygium. So they claim that the CBT100 acts in three ways. It all blocks all the three pathways, leading to this one, all the factors which are relating to pterygium occurrence. So they say that it's like nip it in the bud, so we can make patients free of pterygium.
at present, the role of mitomycin C in pterygium is it's like it can be used preoperatively, intraoperatively, or postoperatively, and it is actually practiced for recurrent pterygium. And there's various protocols that has been followed. So preoperatively you can use it as eye drops 0.02%. 0.02% is as effective as 0.04%. So we can use a lower dosage, lower concentration, so that you can reduce all the complications, and it's been proved that 0.02 is as effective as 0.04%.
Exactly.
And it can be even used intraoperatively or postoperatively. Postoperatively, we prepare drops and give in patients with progressive kind of pterygium, or those who have had a recurrent pterygium. It can be given. So other than that, right now it doesn't have any role. And to reduce the congestion or the symptomatic relief, we can use these medicines.
Yes, sir. Exactly.